I'm going to show you, I'll start by just showing you the planters, and do you remember what this is? An orange stick, right? You saw it once on a slide in medical school and you've never seen it again, okay? This is the second time you're seeing it, and I'm going to leave it, okay? So what we need to do is have some level of tension. So just to show you, so this is all the way up, okay? Too much tension, nothing will happen. All the way down, too little tension, nothing happens. You want it somewhere in between, okay? And somewhere in between, and then about 10 centimeters up is where the tendon is soft enough that it will bend. It's basically like, it's part of the whole terror of neurology, is the terror of the fundoscope, right? It's just, oh, I don't know. And then like, you know, and then a lot of people have this thing, including my wife, who'd be like, you know, I don't know how to close the other eye. So then they're doing this, right? But it's all a thing of practice. It really is. And it's such a comfort to start doing this in practice. So why do our eyes stay stable? So they usually stay stable because they have an ongoing tone from both vestibular peripheral organs, right? So this right vestibular organ is just continually just pushing both eyes like this. So there's always a pulse, yeah? So guess what the left one's doing? Yeah? And that's what they're doing. So let's do a quick demonstration, why not? Put your finger out in front of you. You can see your fingernail, yeah? Shake the fingernail just like this speed. Come on, focus on the fingernail. Can you see it clearly or not? Can you see it clearly? Your eyes are rubbish. Now stop the finger, shake your head, same frequency. Your brain can take a signal of head motion, change it and direct it to the eyes enough that the fovea remains on your nail better than your eyes can track.
Right, so these are some bullet points that are I brought in with me. One is that when you open your books, whatever you read in medicine and then afterwards, we talk about hyperglycemic emergencies. We don't say, but on the other hand, when you talk about diabetes emergencies, you have two subtitles or subdivisions. Okay, one is hyperglycemic emergencies and the other one is hypoglycemia. So hypoglycemia of any sort is considered to be emergent, whereas hyperglycemia per se is not an emergency, okay? Because hyperglycemia is a glucose of more than 11 if you have diabetes. But do you think it's emergent? It's not, okay? So similarly, a very high HbA1c on its own does not warrant an acute admission. So I'm just trying to provoke an alternative approach to hyperglycemia. Your decision making is based on, is the hyperglycemia making them unwell? Is there another condition coexisting with hyperglycemia that is probably causing their glucose to go up and then making them unwell at the same time, so such as sepsis or MI or whatever, okay? And is it causing a degree of ketosis? And we'll talk about ketosis. There are a few slides, on ketosis. Right, and all diabetic foot ulcers require us, no matter how good the ulcer is looking, don't manage them as someone without diabetes. So manage them as take all diabetic foot ulcers seriously and refer all diabetic foot ulcers to the diabetic foot team, all of them.
So the national benchmark is any rheumatoid. We want to see patients within a couple of weeks. And so, essentially you're going to be waiting 6-8 weeks. So this patient who's got inflammatory synovitis, is there anything you can do for them? So I would say actually, so you can send the bloods, okay? And the bloods you would do would be ANA rheumatoid factor CCP, and you could start some steroids, okay? Because there's no point a patient, suffering because of waiting lists. Polymyositis, okay, inflammatory muscle disease, one of the connective tissue disease. If you have a skin rash with it, it's dermatomyositis. And if you have patients like this in your list, in your practice, the things you've got to look out for if they're not well, or when they're presenting first time, is think about respiratory muscle weakness. So as well as them getting interstitial lung disease, they can also get diaphragmatic weakness. So they may feel sort of short of breath when they lie flat. And that's worrying. If you suspect that, they have to be admitted. But I think the window, you've got to remember, the window to your kidneys, at the bedside is the urine dipstick and the blood pressure. I think that they're the key tests to look at the kidneys, because you can listen to the heart, you can listen to the lungs. We're going to come to a stage where you can do an ultrasound of the heart. The stethoscope will be gone. But when you do your abdominal examination, the best you can do is block the kidneys. But that's it. So it's the blood pressure and the urine dipstick, I think, is key. Yeah. Okay, but what's more interesting is what's this picture? Does anyone see what this picture is? What are we looking at? Yeah, the text is, I know. What are we looking at? Optic disc? Optic disc, anyone? Who's got it? That's what it looks like. Optic disc? You've seen this before, what is it? No? No. Tortuous temporal artery? Anyone? Who's got an ophthalmoscope? No, I'm not asking who actually uses one? Do you use them? Good, okay, it's a good skill to have, all right? A good skill. This is not an optic disc, okay? This is someone's scalp, all right? All right, and then there's this maneuver. Anyone done this? The crane rooster? For costochondritis. So it's something you can do, very easy. So if you're not sure, just go behind them, pull their arms up, lift up, and see if it really pulls up the thoracic cage and see if it reproduces pain. And that's supposed to be a good sign for costochondritis. So it's something you can do, and patients will be impressed with that one. Yeah.
Hopefully you're all doing this, checking the pulse. You're all checking the pulse in your patients, aren't you? And if you check your pulse, do an ECG. I have my Apple Watch. When you go to an Asian wedding, your yield of capturing AF shoots up, and you're in a great position to actually get your ECG and prescribe them. If you shake, I have this kind of Vulcan handshake where I shake all these elderly relatives' hands like that, and I'm actually feeling their pulse. Feeling a regular pulse, I'll take my Apple Watch off. I have a very nice Rolex, which I never use because it just tells you the time. This does far more. I put it on them, get them to record their ECG, tell them they've got AF. They then go on their NHS app, prove to me that their kidney function's normal. I get a piece of paper from the hotel, write their prescription, go, right, leave the party, go get your DOAC. Completely doable. The most powerful Valsalva maneuver seen in an episode of ER with John Carter, the doctor, is you dunk someone's head in kind of frozen ice. Super powerful. I suspect you'll be calling your indemnity provider if you try that. I'd stick to the syringe. So just to say, in normal sinus rhythm, you get electricity going from the sinoatrial node through the AV node into the left and right ventricle. So I liken this to kind of my shopping behavior. I'm meeting my wife at Selfridges after this. I'm going to go in, I'm going to get what I want. I know what I want today, as a well done for talking all day, and I'm going to get out. What my wife will do when she's been at Selfridges is kind of go in, one department, she'll buy stuff, she'll try it on, she'll buy it, she'll return it, she'll see someone else buying it. It's very chaotic, okay? So that's kind of what atrial fibrillation is.